Thank you for including our paper in this web series. This paper is joint work with Andrew Komo and Chetan Patel at MIT, my colleague Parag Pathak, and Utku Unver from BC. And what we're doing in this paper is to think about how prioritization policies and mitigation policies for COVID vaccines interact with each other. So these two things have been thought about relatively independently. And in this paper, we're going to think about how we should think about jointly designing prioritization policies for the vaccination with the mitigation policy that have been used so far. So as we all know, vaccination is a key to our goal of reaching herd immunity and to safely lift the social distancing, masking, and remote working restrictions that we have endured for the past year. While the first vaccinations were given in mid-December, it is expected to take a total of 8 months to vaccinate everybody eligible in the United States who's willing to take a vaccine. The current goal of the Biden administration is to have everyone eligible for a vaccine and is willing to take one by July 4th. And this pace is relatively slow because of two reasons. First, there is limited supply of vaccines. But more importantly, even if we have the vaccine doses themselves available, the task of taking the vaccine and putting into someone's arm is quite onerous and poses a number of logistical challenges that have been a problem for a while. And it's finally starting to ease up, but there's no hope of really making it to the finish line before end of June. At the same time, in March of last year, many states adopted phased approaches to reopening, whereby restrictions on workplaces, in density in workplaces, social distancing requirements, masking measures, the types of businesses that were allowed to open, restaurants, indoor stadiums, etc., have been calibrated to the public health measures such as the new caseload, the number of deaths, the use of hospital beds for severe COVID patients. And there's a constant economic pressure to lift these mitigation measures to the extent possible without creating a public health disaster, because there's a huge both economic and psychological toll of abiding by these stringent mitigation measures. While these two things have been largely thought about independently, there's significant interaction between how we decide who should get the vaccine first and the types of mitigation measures that we need to adopt. So in this paper, we're going to think about the interaction between these two aspects of COVID policy. So I'm going to go through how we have been thinking about both vaccine prioritization and mitigation measures before describing our evaluation approach and describing our results. So the vaccine prioritization guidelines have been based on recommendations from the National Academy of Sciences, Engineering, and Medicine, and as well as CDC's Advisory Committee on Immunization Practices. These guidelines have thought about not only saving lives or life years, but also a number of other issues such as reciprocity and equity. Reciprocity for essential workers and healthcare workers who have been working tirelessly and putting their lives at risk throughout the pandemic, and equity in order to address healthcare disparities in the impact of COVID across socioeconomic and ethnic and racial lines. So in these recommendations, there was a phased approach whereby in the early phases 1 and 2, which included a minority of the population, we vaccinated high-risk people, extremely high-risk people with significant comorbidities, people in nursing homes, and the very elderly, as well as some essential workers, such as school workers, healthcare workers, and grocery store workers. The country is now moving towards phases 3 and 4, whereby the general population is starting to get vaccinations. We're not yet at the young adult stage for every state, but some states have opened up vaccination to the general population. Okay, while these guidelines have been used as a basis of allocation, there's significant variation across the country in how these policies are adopted and the adherence to these specific policies. For example, in several states such as Connecticut and Maine, relatively fine age-based prioritization is being used. Connecticut, for example, is right now vaccinating those above the age of 45. Whereas in Alaska, we've already opened up vaccination to the entire adult population. Now, there's also significant differences across states in which comorbidities are prioritized, how they're prioritized, and the occupations that are prioritized. For example, in Massachusetts, higher education workers are not prioritized, whereas in other states like California, they are. So the second thing that we have been doing, in addition to these vaccine prioritization guidelines, is thinking about mitigation measures. Here's a diagram of Massachusetts' phased reopening approach, which was adopted in early March of last year, in mid-March of last year. We started off with strong stay-at-home orders that were gradually relaxed when the cases started falling in Massachusetts over the summer. And at some point, we got to phase 3. Then, during the second wave in late fall, early winter, because of worsening public health measures, we reverted back to more cautious approaches. Okay, so these guidelines look at new caseloads, deaths, hospital bed counts that are being used for COVID patients to try and calibrate the extent of social distancing, masking, reduction in density measures that are required. So in many cases, restaurants were closed down in some cities, whereas other cities, restaurants were allowed to open. Density in workplaces was also regulated very tightly by the states. Okay, so what we're going to do is we're going to think about the interaction between these two sets of policies in the disease dynamics for COVID-19. And we will do that using what is now the workhorse model for simulating the effects, the prospective effects of various policies for COVID-19. This is the SIER model. Its letters stand for the various states an individual could be in. An individual could either be susceptible, which is an individual who hasn't previously had COVID and has no immunity. Exposed, which is an individual who just came into contact with an infectious person and is likely to develop the disease relatively soon. An infectious person who, after the first 3 or 4 days after exposure, has the ability to potentially expose new individuals. And exposure happens for susceptible people when they come into contact with an infectious person. After an infectious period, the individual's case either gets resolved either through recovery, full recovery, or the person passes away. Okay, now the way vaccination helps is by moving people from the susceptible state to the vaccinated state. And for simplicity, let's imagine that vaccinated individuals cannot be ever exposed. Although in the paper itself, we calibrate the probability, the efficacy of the vaccine to the clinical trial data that has been made available. We're also going to assume that the vaccine is transmission blocking, so that an individual who's vaccinated, because they cannot get exposed and cannot get infectious, can never expose another individual. Now, there is some limited evidence that suggests that asymptomatic infections is also reduced if you're vaccinated, although the jury is out there whether somebody who is vaccinated can ever get infectious or not. In the paper, we will assume that, for simplicity, we'll assume that the vaccine is transmission blocking. Okay, we will take this model and we will use an age-stratified version of this model in which the infection fatality rate, which is the probability that an infectious person dies, is age group specific in 10-year bins. In addition, the contact rates between susceptible and infectious individuals will also be age pair specific. So older people or younger people might have different contact rates with other people in general, and also may have different contact rates with people of different age groups. Okay. Now, the role of mitigation can be introduced into this model by reducing contact rates. So think about masking, social distancing, and other types of mitigation measures as simply reducing the number of dangerous contacts that can occur between infectious and susceptible people. And so what we're going to do is we're going to simulate the dynamics of this model and think about the various vaccination policies and the mitigation policy. So here is Here's a look at the contact rates and the infection fatality rate in our age stratified model. Our model has 8 age bins in 10-year groups, and the last group, 80 plus, is in one single bin. But I've aggregated these to 0 to 20, 29, 30 to 59, and 60 and above. On the left side, I'm showing you the daily contact rates. This is the number of contacts per day that are expected to be infectious from survey data. And this is pre-pandemic contact rates. Okay, so as you can see, the elderly have the lowest contact rates overall, but the elderly individuals, those above 60 plus, are more likely to interact with people above the age of 60 than individuals below the age of 30. Similarly, the individuals below the age of 30 are more likely to have other social or workplace contacts with other individuals of the age less than 30, but fewer contacts with older individuals. And in each age group, you see that there's more contact within the age group than across age groups. But the contact rate is declining overall with age. Okay. In this picture, I've also shown you the IFR, which is the infection fatality rate, which is the percent chance that somebody in that age group is going to die from COVID-19 once they contract the disease. Amongst the age group of 0 to 29, the IFR is 0.005%. So that is a very unlikely outcome that somebody in that age group is going to get a severe case of COVID and then after that pass away from COVID. Above the age of 60, the IFR is almost 5%. So there's a 5% chance for the elderly of dying from COVID should they get it. Okay, so now let's think about how you might decide to prioritize individuals from these different age groups if you wanted to minimize deaths. And there are two different forces at play here. First, there is a steep IFR age gradient based on meta-analysis that have been done by others. And this steep IFR age gradient pushes you towards vaccinating the elderly because they have the highest risk of passing away if they get COVID-19. Okay? But assuming a transmission blocking vaccine, there is another force at play. The contact rates amongst the young are also the highest. So if you're a young person and the vaccine is transmission blocking, then giving this young person a vaccine creates a positive externality in others because it limits the spread of the virus, and therefore indirectly also can protect the elderly. Okay, so these two forces result in broadly two types of protection and vaccination prioritization strategies, which are either protection strategies or containment strategies. A containment strategy is to limit the spread of the disease by vaccinating the spreaders. These are the young in this model. Okay, a protection strategy is to give up on limiting the spread of the disease, but protecting those who are the most vulnerable. Okay, and so these two forces together will determine which strategy is optimal. Now, what we did was estimate what is the optimal or the death minimizing strategy, prioritization strategy, under two scenarios. The first is a mitigation scenario in which the measures are held constant throughout the vaccine rollout. So we call this sustained mitigation. So these keeps restrictions fixed at the levels of mitigation that we saw in December and early January throughout the vaccine rollout all the way through June, July. The second is a calibrated mitigation strategy, which eases restrictions as the cases fall, in order to try to minimize the economic harm while maintaining reasonably good public health outcomes. So in the case of COVID-19, it turns out that age-based prioritization, which is a protection strategy, is robustly optimal irrespective of whether we follow a sustained mitigation strategy or a calibrated mitigation strategy. The way you can see this is in the black lines in the figure on the left. The black lines are the optimal or the death minimizing strategy, and the horizontal axis gives you the number of days since the initial vaccinations began on December 14th, 2020. You can see that we get to first, the optimal strategy here is to first vaccinate the elderly. Their vaccination rates steeply climb before they plateau out. They plateau out because there is some vaccine hesitancy, which we calibrate based on surveys from the US Census Bureau. After the elderly are prioritized, our model says that irrespective of whether we use sustained mitigation or calibrated mitigation, ages 30 to 59 should get vaccinated. You can see this by around day 60, we start seeing some vaccination for that middle age group. And once enough people from that middle age group have been vaccinated, the model recommends vaccinating individuals below the age of 30. Now that level is relatively low because right now the authorizations for the vaccines only extend to individuals who are above the age of 16. So only about half of the individuals in the lowest age group are even eligible for the vaccination. Okay. Now, this optimal strategy differs from two benchmarks in the paper. The first benchmark is a random prioritization, which is none. So no prioritization, which is none, which is given in the blue lines. This vaccinates people in proportion to the population. And you can see that the black lines heavily lean on the age gradient as opposed to the blue lines. The third line in these figures are the red lines, which are the NASEM, the National Academy of Sciences, Engineering and Medicine's recommended prioritization schedule. So in order to simulate this, we took data from the American Community Survey, which has detailed information on occupation as well as household age structure, to simulate who would get the various doses of the vaccines if we strictly followed the NASEM guidelines. The NASEM guidelines does prioritize age. You can see that in the top two panels, the red line is above the blue line, but it is not close to the black line. So it does not prioritize age as much as what the death minimizing strategy would recommend. Okay. So it turns out that this protection strategy of prioritizing the most elderly is death minimizing because of two reasons in COVID. First is that the case counts that when vaccinations began were extremely high. On December 14th, we had just come out of the Thanksgiving holidays, and we had a significant surge. Once case counts are high, it becomes quite difficult for vaccination pace to keep up with the spread of the disease, and you have to engage in a protection strategy. The second factor is that as I showed you earlier, the IFR age gradient is rather steep. So people above the age of 60 have a several factor higher probability of death from COVID than people who are under the age of 60 or people who are under the age of 30. And that pushes very strongly towards vaccinating the elderly if you are to minimize deaths. Okay, but the takeaway from the slide is that relative to NASEM, relative to NASEM, the death minimizing strategy prioritizes age more finely and more heavily. Now, what would happen under these two mitigation scenarios if we were able to follow the age-based prioritization strategy? And how does that compare with the other two prioritization scenarios that I discussed with you? On the top graph, we have the predicted path of new cases of COVID under the two mitigation scenarios. If you get mitigation fixed at the December levels, our model predicts that there'll be a slight increase in cases, but then there would be a quick decline afterwards as vaccination catches up and we start reaching herd immunity. Notice that cases decline even before herd immunity is reached. The herd immunity lines, thresholds are given in these dashed lines, these dashed vertical lines. And the prediction in the model is that herd immunity was about 5 to 6 months away if 30 million people could get vaccinated per month. Okay. If we raise mitigation measures gradually as case counts fall, which is the calibrated mitigation strategy, then case counts don't fall for a long time before finally we attain herd immunity and case counts start falling. This is because as we raise mitigation measures while case counts are falling, we end up canceling out the effect of vaccination by reducing social distancing or masking measures. On the bottom two graphs, I'm showing you the cumulative mortality per 100,000 under these three prioritization scenarios. The age-based prioritization scenario, which is in black, the no prioritization scenario, which is in blue, and the NASEM's recommended guidelines. By construction, the age-based prioritization scenario, the optimal prioritization scenario, is going to reduce deaths the most. It's going to result in the lowest cumulative mortality per 100,000. But what is remarkable is that the gap between the black and the blue lines is significantly higher on the right side with calibrated mitigation as opposed to sustained mitigation. So if we end up raising mitigation measures or lifting restrictions as case counts fall, then we will end up undoing some of the benefits of the vaccination campaign by allowing the disease to spread to the elderly, in particular to the elderly. Okay. In fact, at this point, any deaths delayed through mitigation measures are essentially lives saved because vaccinations are not that far away. A second remarkable point in this graph is that the black lines on the left side and the right side on the bottom panel, which show you the cumulative mortality per 100,000 in the age-based prioritization scenario, are quite close to each other. What this is saying is that if we followed an age-based prioritization scenario, prioritization policy, then even if we raise mitigation measures as opposed to sustaining it through to the end of June, the change in the number of deaths, the cumulative mortality, would not be that high. This is because the protection strategy is kicking in. We are protecting the elderly through vaccinations as opposed to through mitigation measures. And that allows us to raise mitigation measures while not affecting total death counts as much. So in summary, mortality is higher if either the elderly are not prioritized or if mitigation is eased. But abandoning both prioritization and easing restrictions leads to significantly high deaths. Okay. Now, in these figures, in this paper, we've also looked at differences in speed across various scenarios, and the differences in speed have a relatively modest effect on total mortality as opposed to either mitigation measures or appropriate prioritization. So in this paper, we showed that fine age-based prioritization, even in the current phases, in the general phases, such as the approaches that is being taken in Connecticut, might have value in reducing deaths. And easing mitigation during this period is likely to increase deaths, even though many people are getting vaccinated. And this is especially true in states and areas where age-based prioritization is not being followed, and most of the elderly are not yet vaccinated. These are some simulations which come along with some caveats. Some of them are listed here. First of all, we are using an age-based approach to stratify the model, and there's obviously some finer heterogeneity in contact rates. Contact rates might vary by socioeconomic status, by occupation, by where you live, etc. And there might be heterogeneity within age groups in the risk of death from COVID because of comorbidities. And these factors can affect and can be good rationales for the types of prioritization strategies that have been recommended by NASEM, for example, where comorbidities and occupation have been considered. New variants are also on the rise, and these variants can influence vaccine efficacy. But our guess is that these variants, if the vaccine is effective at all, are more likely to push us towards age-based prioritization. Third, vaccine hesitancy is becoming an issue these days. And the presence of vaccine efficacy is more likely to push us towards emphasizing mitigation approaches. And finally, there's a question mark around whether vaccinated individuals can transmit the virus. In our model, we assume that the vaccine is transmission blocking. This is consistent with recent evidence, particularly from Israel, that shows that the vaccine does reduce asymptomatic infections, but it is not definitive about whether the vaccine does reduce the transmission of the virus. So despite these unknowns, we believe that thinking jointly about mitigation approaches and vaccine prioritization is valuable in shaping the policy discussion in the current phase. Thank you very much. Done.